Sir, we are live now. With all your permission, sir, I am starting this session.
Sorry for being late.
Sir, I will introduce you, sir, and then I will hand over to you, sir.
Oh.
Just give me a very good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Bodhyan Bhattacharya sir. Sir has done MBBS from Medical College Kolkata, MD in Tropical Medicine, and Syrian resident in the Department of Infectious Disease and Advanced Microbiology, School of Tropical Medicine, Kolkata. And today, sir is going to discuss on a topic, Nipah virus, an overview. Let me tell you overview of the topic before starting this session. As we know that in the world of Nipah virus is a highly infectious zoonotic pathogen that is cause outbreak in the South and Southeast Asia, posing a significant public health threat. This webinar provides a comprehensive overview of the Nipah virus, covering its origin, transmission, clinical manifestation, and diagnosis and prevention strategies. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Good evening to all. As already mentioned, the topic of discussion is Nipah virus. Every last 2 to 3 years, we have been hearing this viral infection from Kerala, especially from Kozhikode and Kochi, from 2018 actually, 2018, 2020, we are hearing this virus outbreak. So we have just finished one, battled out actually one pandemic, COVID. Now new virus outbreak is really worrisome for all of us. So I will briefly give the overview, that is clinical features, diagnosis and management. Basics of virology: Nipah virus is a zoonotic virus. It is an RNA virus. It is mostly initially found in the Malaysian village, that is Kampang Sungai Nipah. So the virus was named as per the name of the village, Nipah, and it falls under the family of Paramyxoviridae and genus Enipaviridae. It is category C priority pathogen and BSL-4 pathogen. So anyone who is handling this virus related work should have one BSL-4 pathogen laboratory. So this is not commonly available all over India. In IV Pune is one of those. Actually, this viral infection was first noticed in Malaysia in 1999. That was a outbreak from a infected pig actually. The farmers were handling the pigs. Then from pig, the viral disease spills over to human and ultimately caused this outbreak. And after that, several reports of outbreaks occurred in Bangladesh, India, and Philippines and Singapore. Philippines and Singapore outbreaks are very small, but Bangladesh and India, especially Bangladesh, the outbreaks was very huge in number actually. And if we consider this structure on the right of your screen, the main portion I want to mention, that is the one fusion protein, that is F protein, and G protein, that is attachment protein. Because these things knowledge will be helpful in our treatment modalities. So if we see the Indian scenarios, total 6 outbreaks had occurred, including this year's outbreak in September in Kozhikode. Actually, the first viral outbreak occurred in West Bengal, Siliguri. Actually, one patient got infected from eating this rice. This actually dead palm sap actually. That is, we always call it in Bengal, that is tari. So this virus spilled over to human, and then the patient got admitted to a local hospital in Siliguri, and ultimately the infection actually spreaded through these healthcare staffs and the persons who visited the patient also. So ultimately, number of cases was 66, and with a huge fatality, as 68%. After that, there is outbreak of Nodia. 5 patients, 5 days, 100% mortality. So this is really a highly fatal viral disease. And in all those cases, there is a history of taking some dead palm sap, that is toddy, from some tree. So after that, the virus spilled over to the human. And also there have been several outbreaks in Kerala, that is 2018, 19, 21, and 23, with a variable mortality of some outbreak is having 89%, 100%, and some is having 33%. So if you add up all the figures, cases, and deaths, the mortality comes to 71%. This is the world map of the Nipah virus presence. The red ones are where the Nipah outbreak had occurred. You can see that on the map, Bangladesh is badly hit, and also Kerala and parts of West Bengal and Singapore and Malaysia. And also it is actually transmitted by these flying bats, that is pteropods bats. Actually, this bat is prevalent in the areas where there is marked with yellow. So the zones which are marked with yellow are potential for having outbreaks of Nipah virus. So bat is there, pteropus bat, and it is called flying bats. Actually, they actually eat some fruits. When they eat some fruits and contaminate the fruit, the humans accidentally consume this contaminated food, and the disease can spill over to human, from human to other humans. So in India, it has been seen that the human to human transmission occurred, but in Malaysian outbreak, usually human to human transmission didn't occur initially. So for Indian variety, we can get human to human transmission or hospital outbreak. But suppose one patient admitted with suspected Nipah, ultimately got a report of positive Nipah infection, then the subsequent patients, like the patients who are lying nearby in the nearby beds, can they get the infection, and also the visitors, and also the doctors, nurses, and other healthcare staffs. So it is very worrisome, that is, if this one suspect patient gets admitted to our hospital, then all our healthcare staffs are at risk. And usually there is no apparent disease in bats, because bats are the reservoir. They usually carry this virus, and pigs are intermediate hosts. The R naught, that is infection rate from one person to another, is 0.43. From our COVID experience, we all know that the COVID has a R naught of almost 2 to 3. So it has a high potential of developing into pandemic. But for Nipah, there is a little chance of pandemic, because R naught is less than 1. So in any viral disease or any disease which is having R naught of less than 1, there is less chances of developing epidemic or pandemic. So we might see certain spots of or huge cases of cases in a certain locality, but ultimately it may not develop into some pandemic. And there is a seasonality, that is December to May, because these times bats usually contaminate this date palm sap, and there is toddy, and also they consume some fruits. Usually the people behavior also, it is such a way that they search from some fruits in this season from the tree actually. So it has been seen in Kerala that this season is common, but to the contrary, that is in this outbreak in 2023, the outbreak has occurred in month of September. So seasonality is not always the rule. It can always occur anytime, anywhere. And two Nipah virus clades are there. This BD genotype, this is Bangladesh genotype, and MOI genotype, that is Malaysian genotype. Actually, BD genotype is can cause, I have already discussed, that is, it can cause this human-to-human transmission, and Malaysian genotype usually doesn't cause human-to-human transmission. And one particular thing is with the BD genotype, that is, it can cause encephalitis with some ARDS, like acute respiratory distress syndrome. So lung involvement along with encephalitis is very common in Bangladesh. strain, and Indian clade is also similar to Bangladesh strain. So India and Bangladesh clade are BD and Malaysian are MY. So Malaysian clade doesn't have the human-to-human transmission, and the lung involvement is not there, only encephalitis feature. And one same virus is there in the same family, the Nipah family, Hendra. So Hendra, Nipah is having some amino acid or nucleotide homology. Again, Hendra that might be working against this newly developing or emerging viral disease. So this is the concept I want to show you, because it has some nucleotide homology or amino acid identity up to 80 to 90%. The transmission I have already discussed. It is direct transmission from the infected animals via consuming contaminated foods and close contact with a person or their body fluids. So there is a potential healthcare setting outbreak. First known Nipah virus outbreak in Malaysia was due to close contact with infected pigs, not due to bats. And domestic animals like horses, goats, sheep, cats, and dogs, pigs can get also this infection. But bats usually doesn't develop the disease. And there is a particular term that is used in veterinary science, that is barking pig syndrome. When pigs get infected due to encephalitis, there is some bark in a some peculiar way. It is called barking pig syndrome. It is a transmission cycle I have already discussed. In India or Bangladesh. It is BD clade, raw dead plum sap, that is tadi, usually humans consume. Then the patient gets admitted to a hospital. From hospital, the infection spreads to other nearby patients, healthcare staff, doctors, nurses, and also even visitors. And in Malaysia, usually the transmission cycle is from pig to human. And in Philippines, from horse to human transmission has been documented. What are the signs and symptoms? It is usually a asymptomatic infection in a very mild percentage of cases, 1 to 4% of cases. But maximum cases develop encephalitis. Incubation period is 4 to 14 days. So longest is 21 days. That is important because if anyone comes to a contact of a suspected or proven case of Nipah viral infection, then we have to observe the patient or isolate the patient for at least 21 days, 3 weeks. Initial symptoms can be fever, headache, cough, sore throat, difficulty in breathing, vomiting, non-specific thing. Severe symptoms are drastic, usually may follow within 24 to 48 hours. Disorientation, drowsiness, confusion, seizures, coma, and encephalitis may follow. The mortality is 40 to 75% according to CDC data. So it is a highly fatal death as you compare to COVID. It was only 2 to 3% of mortality. So it can be a small outbreaks in clusters in some parts of the world, but it can be merely 100% fatal in some cases also. High fatality is the rule. So when we are dealing with these encephalitis, we should keep in mind in other viral encephalitis like JE, Japanese encephalitis, measles, rabies, dengue in this season. In this tropical country, it is very common, and malaria are also common. Scrub, leptospirosis, herpes, and bacterial meningitis. These are the differentials we should keep in mind always. So it is not always that the Nipah will be suspected from the very forefront, because these are more common than Nipah. So you should keep in this differential in the back of your mind, so that you cannot miss these common problems like dengue, malaria. These are very common. Scrub is very common cause of encephalitis in India. So you should keep these differentials in mind. So what are the clinical features? It is similar to a viral disease, thrombocytopenia, leukopenia, raised liver enzymes, hyponatremia. And CSF analysis may show raised proteins, lymphocytic pleocytosis, normal glucose levels. And imaging may show 2 to 7 millimeter of multifocal discrete lesions in subcortical and deep white matter. Actually, these are not specific changes, global changes, bilateral, subcortical, and deep white matter changes is there. This is not normal specific, but this has been seen. So there has been some specific test for Nipah virus, that is ELISA for detection of antibodies, and PCR and virus isolation. This is the pathogenesis. Usually the Nipah presents as a atypical pneumonia. Obviously, non-bacterial pneumonias are usually atypical pneumonia. It is the inhaled this initial stage, inhaled this viral particle. When we inhale, these epithelial cells are get infected by this viral particle. Ultimately, it goes to the bronchi and alveoli, and ultimately infects the epithelium. Ultimately, it goes to the lungs, and it can be, the virus can be bound to leukocyte. Virus can be free from leukocyte or free bound, free virus. It can go up to brain, spleen, or kidney, ultimately leading to organ damage. It's not only brain, so spleen, kidney, lung, all are affected. So when to suspect Nipah case? Persons from a community affected by Nipah virus outbreak who has fever with alternate mental status or seizure, headache, cough, or shortness of breath. So any three we have to suspect. That is alternate mental status or seizure or headache, cough, or shortness of breath. And what is a probable case? Suspect patient is the same village or what the ward, but the suspect patient has died before the diagnosis or the workup has been completed. So it is a suspect case, because the suspect case which was present in the index cases village or ward has died. So investigation could not be done. So it is a suspect case. And also is the same for the hospital admitted patient. Suppose the patient was suspected as Nipah viral infection, investigations were being said, but somehow it could not be sent in due time. The patient died. Then the nearby hospital patients are a probable case. And confirmed Nipah virus case is Nipah virus RNA identification by PCR in respiratory secretions, urine, or CSF. But CSF examination is not mandatory, it is optional. So respiratory secretion, urine, blood can be also considered for sample collection. And who is a contact? A person of a part or a patient who came in contact with the Nipah case, confirmed or probable case. Suppose the patient has been admitted simultaneously in the same hospital ward, has a direct close contact with suspected confirmed case of Nipah virus during transplantation, or has attended this burial preparation of the disease, or has touched the bloody fluids or blood, or has touched the clothes or linings. But this is a less risky thing to touch these clothes and linens, and then it to be followed up for appearance of symptoms of Nipah viral infection for longest incubation period, that is 21 days. So for diagnosis, if for live patients, we should send CSF, throat swab results of blood, urine, and dead subjects. We can consider spleen, kidney, and lung biopsy. RT-PCR, we all know, all our labs are equipped with this machine in COVID days. So it is very common to us. RT-PCR has to be done for the RNA detection, and antibody detection can be done IgM or IgG via ELISA. Actually, antibody should be sent after 5 days, as any other viral disease, and cell culture for experimental use. Samples should be collected for in VTM for throat swab, urine 10 ml in sterile container, blood at least 5 ml, CSF at least 1 ml, and preferably within 4 to 5 days of the onset of the illness. And sample to be sent to the BSL-4 lab, that is in NIV Pune, and the sample should be sent in a triple container packing and should be transported under cold chain. This is the case record form we have to fill out, because before we are sending these samples to Pune, the first page contains identification, second page contains symptoms of examination, next page is comorbidities and epidemiology, and next page is sample type, which is the sample: oropharyngeal swab, nasopharyngeal swab, urine, serum, EDTA, CSF, nasopharyngeal aspirate, could be anything, and also lab values, CBC, urea creatinine, all those things, LFT. And also diagnosis and ecological history, that is patient, whether the patient resides in pigs or pig stream nearby, a patient's behavior of fruit bats in vicinity, or unusual death of the animal reported, or contact with the bat excretion. It has to be recorded actually and sent to the Pune NIV. So treatment, we can all see this COVID days, we are all actually used to it. If this outbreak occurs in our community or locality, then the PPE days will be back. Isolation, use of PPEs, hand washing, we all know. and on supporting hydration, oxygen, antiseizure mitigation, mannitol, because there may be cerebral edema. One important thing is that the G envelope protein, that is, I already shown you that the Nipah virus contain one G envelope protein, one monoclonal antibody, that is M102.4, is there, that has been used against the Hendra virus infection in Queensland, Australia in 2001. It blocks the G protein of the NIV, that is Nipah virus, and it prevents the attachment to the eprin 2 beta 2 protein, eprin beta 2 protein of the respiratory epithelium. So ultimately the virus cannot get attached. So monoclonal antibody can be prevented by this method, because obviously this Hendra virus has some molecular homology with the Nipah, so it might be effective. And what about this pan-viral drug, that is ribavirin? Ribavirin has been tried in almost all RNA viruses actually. But one study is there from this epidemic of Malaysia for the Nipah virus. That is, they have used this ribavirin in a high dose, that is 2 gram on day 1, 1.2 TDS on day 2 to day 4, 1.2 BD on day 5 to day 6, 0.6 BD for another 1 to 4 days. And they have shown that the ribavirin treated leave is favorable in terms of mortality. It is 32% in ribavirin treated group, and placebo is 54%. So there is significant reduction in mortality in this Malaysian study, but the sample size was okay. But subsequently in Bangladesh and Kerala, no studies are shown to be much more effective. But that's why the IDSA 2008 encephalitis management guideline, they have recommended it as C3 recommendation. And then another COVID drug, we know all are familiar with this drug, favipiravir, Japanese molecule. And this article has been published in a good journal, that is Nature. The Syrian hamster model has showed that the 14 days favipiravir can give the protection of lethal dose of Nipah viral infection. So what about remdesivir? Another COVID drugs, all the COVID drugs are coming back in this infection. In AGM means African green monkey. In this model, they have given remdesivir up to 12 days. And there has been some benefit of this decreased infection or milder infection. Only 2 of the 4 treated animals developed the disease. And who developed the disease, mild respiratory symptoms were there, and the symptoms usually resolved by day 40. What is the discharge criteria? We all know in COVID days, we also seeing what is the discharge criteria, RT-PCR 1 positive, 2 positive, and ultimately the RT-PCR testing were obsolete. We can discharge after 7 days. So there has to be some discharge criteria for this disease, highly infectious disease. Obviously, the patient has to be clinically stable. An important point to note that the RT-PCR from all 3 samples, that is throat swab, urine, and blood, has to be negative on 2 occasions at least 5 days apart. So 3 samples on 2 occasions. So 6 samples has to be negative within 5 days. So it is very important. And ultimately, it has to be decided by treating clinician and confirmed by medical board. And we should advise that the discharge for isolation for 28 days, and follow-up should be done on 28 days, 56 days, and 90 days. 90 days. And neurological sequelae are common, that is seizures, personality changes, behavior changes at 90 days. So what are the criteria for discharge of the contact? Suppose the patient came with the contact, like patient touched the bloody fluids, the patient is residing in the same house, or patient has been admitted in the nearby bed of the Nipah viral infected patient. So if the contact is tested negative, then she should be sent to home and asked to isolate themselves for 21 days. Always ask them to keep their phone on so that they can consult telephonically. You all know in COVID days, teleconsultation has become so much popular. And if they are tested negative, but the fever is continuing, then you have to repeat the test after 2 days, and you have to If the symptoms are persisting, we have to repeat the test every 2 days. And also we should consider other differentials of encephalitis like JE, dengue, malaria. You should not forget scrub also. You should not forget. Okay. So it is the algorithm I have already discussed. When the patient has confirmed case of Nipah viral infection, treatment of encephalitis, ARDS, myocarditis is a known complication. We can have this complication, and if it is positive, we can ask for this monoclonal antibody on compassionate ground, because we do not know whether the this monoclonal antibody will be working or not, because this study has been done on Nipah viral infected patients. This has been done in Australia with Hendra viral infection. So we can give monoclonal antibody and followed by this remdesivir to 200 mg, stat followed by 100 mg once a day up to 12 days. So 12 days of remdesivir. Or we can give favipiravir, that is 1800 twice daily for 1 day, followed by 800 twice daily for next 13 days. And ribavirin is high dose, quite high dose. 2 grams stat, 1 gram 6 hourly for 1 to 4 days, and 500 mg 6 hourly for 5 to 10 days. Actually, this ribavirin dose actually has been taken for other viral hemorrhagic fever that is recommended by WHO as a Lassa fever. So they have extrapolated this data of Lassa fever for treatment of Nipah. And some immunomodulators, we all think that steroids are magic molecules. We have seen in COVID, that is steroids, baricitinib, tocilizumab. These are really game changers. And if the patient is having GCS of less than 8 and rapid neurological dissociation, CRS, that is cytokine release syndrome grade 3 or grade 4 or secondary HLH, we can easily use this immunomodulator in the form of steroids or IVIG or tocilizumab. It is under trial. It is no recommendation is there. And for prospective exposure prophylaxis, we can keep this remdesivir and favipiravir. So this disease is something like Ebola and this COVID. So there is some term that is called novel acute immune dysrhythmia syndrome, NAIDS. It is monocytic dysrhythmia. So it is altered balance of the TH1 and TH2. So TH1 takes upper hand and TH2 is less. So interferon is less. So it triggers this mortality in COVID-19. It might be also true in Ebola and Nipah. And there is a lymphopenia and ARDS and multi-organ dysfunction, multi-inflammatory syndrome. So we can try this immunomodulator like COVID. But in dengue, it is not there. Dengue, there is lymphocytosis, and TH1, TH2 balance is not there. So in dengue, it is doubtful. In influenza, it is doubtful whether we can use immunomodulator. But for Nipah, Ebola, and also of course COVID, we can use immunomodulator. This is a new term in the dictionary, that is novel acute immune dysrhythmia syndrome, NAIDS. So I have already discussed for discharge criteria. If the positive report is positive, we can treatment as per guideline. We can discharge as per recommendation. I have already told 3 samples twice within 5 days has to be negative. And if it is negative, we send asymptomatic. We can ask him to go to home and observe for 21 days. Of course, to keep the phone on. And in the symptomatic, we have to repeat the test every 2 days. But we should keep other differentials in our mind. There is a study done in Kerala that is the first experience of ribavirin post-exposure prophylaxis for Nipah virus. This Nipah virus outbreak occurred in 2018 in the parts of Kerala, and they have given this ribavirin doses to 2 doctors and 6 nurses actually. And look at the doses, ribavirin tablets taken and the milligram of ribavirin taken, 40,000 mg of ribavirin taken. And they have classified the healthcare workers according to this duration of exposure. Surprisingly, few also discontinued this ribavirin because of side effects or the afraid of potential adverse effects, because ribavirin can cause hemolytic anemia, it can cause cytopenias, it can cause hepatitis, and it can cause very much problem. So in the fear of this adverse effects, some discontinued, but surprisingly, whatever dose they have taken, none developed ribaviral infection. So ribavirin can be used as prophylaxis, post-exposure prophylaxis. So suppose one emergency medical officer who has seen the suspected Nipah virus case, ultimately the patient turned out to be proven RT-PCR proven actual Nipah viral infection. So we can ask him to take this ribavirin as post-exposure prophylaxis, because he will be highly apprehensive and he will be running around here and there and asking for help what to do. We can ask him to take this drug because what study is there, because this drug has shown some benefit. So what are the disease prevention? Same as the COVID: droplet precaution, isolation, hygiene, and wearing PPE, contact tracing. Obviously, contacts have to be traced, quarantine, and important point is avoid contact with sick bats or pigs, avoid areas where the bats are known to roost, and avoid eating or drinking products that has been contaminated by bats. And obviously, when the disease is so much fatal, some attempt has to be there to develop some vaccine. Only so all the vaccines has been tried in animal model. No human model is there, and they have used these vectors, other viral vectors like vesicular stomatitis viral vector, adenovirus vector, uh, pox virus vector, measles based vector. So they have they are trying to develop some vaccine, but vaccine related studies are in the very early phase because it is in the animal model. To summarize, we should suspect NIV in relevant epidemiological setting. NIV has high secondary attack rate and very high mortality, almost up to 100%. Infection control measures are the key. Ribavirin may be tried for treatment and also for post-exposure prophylaxis. Not only ribavirin, pyravir, remdesivir can also be tried, because we do not know what is actually effective, because we are having less number of outbreaks, less number of patients are there. We could not find one effective drug to treat, and effective control measures are needed to combat this disease, because we have to break the transmission from the animal to humans. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participants who have joined this video session, sir. As I can see, sir, we have received some questions from the participant, and if you allow, with all your permission, shall we take
Yes,
these
yes,
questions?
yes.
Yes, so the first question is from Dr. Anshuman. He is asking, what are the recent advances in the understanding of Nipah virus, immunopathogenesis, and antiviral approach?
Antiviral approach I have already discussed. It is ribavirin, high dose ribavirin can be tried. One thing, favipiravir can be tried, remdesivir can be tried, but usually these outbreaks occurred in small clusters. Usually the total number of cases in the world might be near 200 plus. So adequate data is lacking whether any one particular antiviral is effective or not. We do not know actually. We can try ribavirin, we can try favipiravir, we can try remdesivir. All those things are available because of this COVID outbreak, and we are all having the experience of this using these drugs actually. You can try it. And for immunopathogenesis, I have already mentioned that some Th1, Th2 balance is lost. So we can think of some immunomodulator. Suppose the patient is having ARDS, some patient is having poor GCS with encephalitis, patient is having myocarditis. There is no harm in giving one sort of steroid, because we are anyhow we are going to lose the patient. If steroids can help, we can give it. Scientifically, it is correct. We can try, because it acts like that immunopathogenesis is something similar to COVID. this immune cytokine storm and all those things.
Thank you so much, sir, for sharing your insights on this question, sir. Moving forward, I can see another question from Dr. Banerjee, and he's asking, what are the rules of cholesterol in the early and the late step of Nipah virus membrane fusion cascade?
Fusion cascade means we have to build the replication. Do you want to mean this replication phase? Can he respond? Or it
He has
is
written the
closed?
question is, sir, what is the role of cholesterol in early and late step of Nipah virus membrane fusion cascade? The question is this.
Actually, Nipah virus, this fusion protein is there, and cholesterol is needed for this fusion to occur. Actually, it gets after fusion, it gets internalized, and this ultimately infects the cell. It has some role.
Okay, thank you so much, sir, for answering. I will be taking last question for today's session from Dr.
Yes.
Agarwal. He is asking, what is the interaction between the Nipah virus, nucleocapsid protein, and phosphoprotein regulates virus replication?
Actually, these are virology questions. Um, Probably I am a clinician. It is very difficult to answer actually. Some capsid fusion capsid is needed for this capsid. Virus as a capsid is a fusion protein, is a G protein attachment protein. Some phosphorylation has to be there to for the virus to enter actually. I think virologist can answer it better in a better way.
Okay, sir. Thank you so much, sir. I hope that as I can see, there is no more question from the
Thank
participants,
you.
sir. I hope you are made justice to the topic, sir. I hope it will be very useful and insightful to all the doctors as well as the general public also. Like it has been spreading in time to time, people will be careful and take precaution regarding this virus. Sir, as there is no more questions, sir, with all your permission, shall we conclude this session?
Thank you.
Okay, thank you so much, sir, and take care of yourself and happy Durga Puja in advance and hope to see you again with different
Thank
topic
you.
in future, sir.
Thank
Bye,
you.
sir. Take care.